Hi students, this is Dr. Ways and welcome to your lecture on upper limb joints. So the shoulder has several joints, a couple of which you may not readily think about. One is the sternoclavicular joint, and that is where the clavicle right here articulates with the manubrium of the sternum. Right here at the clavicular notch next to the jugular notch right here. All right, and then if we follow the clavicle all the way over, and you can see it's actually connected to the coracoid process here as it passes over it by the coracoclavicular ligament, all right, which is composed of two separate ligaments here. I don't care that you know the names of these two, but the coracoclavicular ligament would hold the clavicle in place over the coracoid process. And then we have the acromioclavicular ligament, which is attaching the clavicle to the acromion to finish out the shoulder joint associated with the clavicle, or the shoulder joints associated with the clavicle. And then we have the primary shoulder joint that we think of when we think of shoulder joints, and that is the glenohumeral joint. So the glenoid cavity of the scapula with the head of the humerus. And as you can guess, it is a ball and socket joint. If we look over here at the radiogram, here's the head of the humerus and the glenoid cavity of the clavicle, and it's a ball that fits into more of a shallow socket, but still it's a ball and socket joint. And remember, ball and socket joints are synovial joints that allow for movement in all directions. And one thing to note about this joint before we talk about it any further is that the biceps brachii muscle actually is attached to the superior border of the labrum of the glenoid cavity, and then goes down on the anterior side of the head of the humerus through this transverse humeral ligament and then down to the actual muscle itself. So like other joints, synovial joints we talked about, the ball and socket joints in particular, we have this green synovial membrane that's surrounding the joint itself, all right, providing lubrication. Remember that synovial joint is the only place where exchange with the blood occurs. And then the entire joint is wrapped in these fibrous ligaments that are designed to hold the joint together. The synovial capsule, or the synovial membrane of the glenohumeral joint, is continuous with the synovial sheath of the long head of the biceps brachii tendon right here as it passes under the transverse humeral ligament. And just one more thing to point out here is this redundant synovial membrane and the purpose of that redundant synovial membrane. Think of it as a loose piece of synovial membrane that's kind of hanging there. And when the arm abducts or pulls away from the midline of the body, this synovial membrane with the fibrous capsule will pull tight and allow for that abduction of the arm without compromising the joint or compromising movement of the joint. Surrounding the joint, we have our rotator cuff muscles, and they consist of our infraspinatus muscle, our teres minor, our subscapularis muscle, as well as our supraspinatus. So those four muscles that we see in gray here, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, all the way around this glenohumeral joint are known as our rotator cuff muscles and allow our shoulder joint to rotate in multiple directions, which is why you see them around the joint. And on the left here you see radiographs of the glenohumeral joint. Notice you don't see muscles there, and you see this space between the joints. You don't see the ligaments either, so the ligaments don't have enough density to be able to see clearly on an x-ray, and you should be able to recognize that in x-rays that you see. So this will be your first exposure to looking at these types of images. All right, remember the shoulder joint is a ball and socket joint that allows movement in all directions, pulling away from the body, abduction, adding back to the body, adduction. From the back, from the front here, flexion as we move our arm out in front of us, extension as we pull it back to the midline of the body, and hyperextension would be behind the plane of our torso. We have lateral rotation, outward, and medial rotation inward, and then we have all of them together known as circumduction. In addition, because of the way the glenohumeral joint is attached to the scapula, we also have this phenomenon of retraction, where we can retract our arm behind us and then protract it out in front of us by moving the scapula itself instead of just the arm at the glenohumeral joint. Moving on to the elbow joint. The elbow joint's a little more complicated, even though it is a hinge joint when we're considering the ulna, as it is articulated with the humerus, but there is also a rotation component when you see that where the radius is articulated with the humerus. So with the ulna, it's hinge. With the radius, it is a rotation. And so with the hinge joint, you can do flexion of the elbow and extension of the elbow. With this particular joint, you can't do hyperextension because this olecranon process can only go so far. And then with the rotation component of the radius, you can do pronation, which is turning your hand, if you're standing in anatomical position, so that the back of your hand is facing forward. And then supination is turning your hand back over so that the palm of your hand is facing forward. So notice that the synovial membrane is covering the trochlea, where it interacts with the ulna, and is also covering the capitulum, where it interacts with the radius. So you have that synovial joint with synovial fluid in there. There are fat pads here on the anterior portion of the humerus here to act as a pad for when flexion occurs and those bones from the forearm come in contact with the humerus. When we're looking at this joint in a radiograph, here's the humerus. You can see the medial epicondyle here, lateral epicondyle here, and this is and the ulna here, the radius here, and then the ulna here, with the olecranon process coming from the back. So this is what we call an antero-posterior view, which means you're taking a picture from the front and looking through the back. So you can see actually right through the humerus where the olecranon process fits into the olecranon fossa there. All right, so covering that synovial membrane, like the other joints we've seen, you have these ligaments between the humerus and the radius and the ulna. We have this annular ligament of the radius, which wraps around from the anterior portion of the ulna to the posterior portion of the ulna and allows the radius to rotate within that ligament because it goes around the head of the radius. We have the ulnar collateral ligament, the radial collateral ligament. Those are similar to what we see in the knee joint, where we have a lateral collateral ligament and a medial collateral ligament. And of course, the purpose of them is to hold bones together as the joint is in movement. So on the right here, we see an MRI of this joint. Here we see the head of the radius right here. Notice that round portion. Here we have the ulna. And with MRIs, we can actually see the ligaments and detect whether or not they are intact. So here we see the ulnar collateral ligament here on the medial side, and then a radial collateral ligament here on the lateral side. And then, of course, you can pick out other structures here, such as the trochlea, the capitulum. So one of the things that we're going to have you do through this course is look at images of bones, because you're never actually, unless they're sticking out due to an injury, going to see a bone or you're doing surgery, see a bone in a patient. So it's a good idea to get really familiar with images as they come up and identify the structures that we are learning in this class. All right, so this slide is just showing you what we've already shown you in a previous slide: the flexion and the extension of the forearm at the elbow, and then of course that pronation where the back of our hand is facing forward, then supination where the palm of our hand is facing forward. Notice that in pronation, the radius crosses over the ulna, and in supination, you're going back to the radius being next to the ulna. All right, the wrist and the hand joint consists of your carpal bones, as well as your metacarpal bones and the phalanges. So this is the right hand here, so you're looking at the palmar aspect of this hand. And I want you to remember that right here we have our distal interphalangeal joint. Here we have our proximal interphalangeal joint, and here we have our metacarpal phalangeal joint between the metacarpal and the the first phalange, or the proximal phalange rather. All right, we didn't cover this before, but I just see it, so it reminded me of it. The thumb also has two sesamoid bones, kind of like the big toe did. So just to point those out, because I forgot to do it before. And this radiograph here, both of these actually are showing you all of the carpal bones that I mentioned before, the scaphoid, all the way around, back up, starting with the scaphoid all the way around and back up. And then here is showing you a fracture. You can see that fracture within the scaphoid, showing you that you can break bones of the carpals. And in fact, the scaphoid bone is the most common carpal bone that is fractured, and typically from falling on your wrist, using your hand to brace you. Notice also that at the MCP joint, we have these palmar ligaments, and through those palmar ligaments will be the tendons that are part of our forearm flexors. So they'll be held in place by those tendons, and of course there'll be a synovial sheath surrounding that so that there is no friction as the tendons are being pulled. All right, so this picture I pulled down just to show you, because we often forget that where these bones are actually in our hand. And so you see the carpal bones right here that are making a joint with the metacarpal bones. So your carpal bones of the wrist are here, and then your metacarpals would begin right here, and then it would extend upward. So again, noting that your metacarpals are actually within your actual hand. They haven't split out and become fingers yet at that point. And then this is also a nice figure showing you the distal proximal interphalangeal joints, the metacarpal phalangeal joints, as well as the carpal metacarpal joints, and then the interphalangeal joint here at the thumb. And again, this is going to be a really good picture to know, because when you get to physical exam lab, these are going to be mentioned quite a bit. These joints are going to be mentioned quite a bit, and you're going to be assessing those particular joints. So good to know them now so that you have that basis when you are doing your physical exam later on. All right, so another picture. This, of course, is the palmar aspect of the hand. You know that because we see the flexor retinaculum here with all of our flexors going through. We have the synovial sheath that's around them, so that when you pull on the tendons, they move relatively frictionless. And then of course these palmar ligaments that we showed you in a previous slide, and those are going to be on each digit, and the tendons are going to go to each one of those, through each one of those ligaments. And of course they're going to be covered by synovial sheaths, which will be covered by another fibrous digital sheath, allowing for layers of protection of those tendons that are pulling on the joints that allow for flexion of your hand. All right, this picture is showing our extensor tendons going out to the digits as well, so that when the flexors are relaxed, the extensors will extend the finger back out to a straight position. And the purpose of this slide is to show you mainly to show you the extensor hood right here, which acts as a sheath, covering the posterior portion of the fingers. But one of its main function is to allow the MCP joint to be flexed while the rest of the fingers can be extended. So this extensor hood allows that phenomenon to happen. And so you see here where you have the MCP joint flexed as well as all the other fingers flexed. The MCP joint's flexed, but all the rest of the fingers are extended, and it's because of this extensor hood that we can do this. All right, so just to remind you the movements of the hand, if we use our middle finger as the midline, anything going away from that in either direction is abduction, and then going back towards the middle finger is adduction. Our hand itself can abduct and adduct, so notice abduction is away from the midline towards the thumb. Adduction is back. Our hand at the wrist here can flex, which would be a palmar towards the palm, and extend, which would be towards the back of the hand. Imagine yourself in anatomical position and practice these movements. And then of course, because of the hinge joint right here, as well as the carpal joints, we are able to do flexion, extension, abduction, adduction, all in a continuous movement, which we call, of course, circumduction.